Dear colleagues, dear chairman, it's a pleasure to be here and to discuss about this topic of arterial hypertension and the new guidelines. As you know, I will speak a little and you should intervene a lot because you have more time than me to speak. So just to show you the state of the guidelines, there are the European Society of Cardiology and Hypertension guidelines that came out last year. But you know, of course, that there are guidelines overseas in the United States. There are guidelines in the UK. There are guidelines in Australia. And in order to make it more interactive, I decided to show you, of course, the guideline from the European Society of Cardiology and Hypertension, but also to compare and to see the difference. And this may be a reason to intervene and to challenge the new guidelines. So I will start with the definition and then I will go over the strategy, how to measure blood pressure, ambulatory blood pressure, and then how to stratify the risk of our hypertensive patient. Then I will have a word on treatment, and finally the discussion will follow. So there is nothing really new in the definition of hypertension. You keep the definition of 140/90 millimeters of mercury for office blood pressure. In order to have the diagnosis, you need, once you measure two measurements on one day, and on a separate day, you need a second time over 140/90 millimeters of mercury. But with the new technology, you have now new device that help you focus the diagnosis of hypertension. And these are the ambulatory measure, whether it's measured over 24 hours or at home by the patient. Most of our patients now have a device they can use at home. The important thing, of course, is how to use this measure. So these patients should be taught on how to measure good blood pressure, as the doctors and the nurses are taught how to measure good blood pressure. And you see that the definition between daytime 24-hour blood pressure and home blood pressure is not that different. If you have the mean of your blood pressure that is over 135 or over 85 millimeters of mercury, then you can say that your patient is hypertensive on the ground of ambulatory blood pressure measurement. If you look at nighttime blood pressure, the definition is 120 over 70 millimeters of mercury. And some use also 24 hours blood pressure, and this is 130 over 80 millimeters of mercury. So what is different with other guidelines? If you look in the UK, they have the nice guidelines and they say they keep the same measure, but they insist on confirming the diagnosis of hypertension with an ABPM. That means ambulatory blood pressure measurement. And now it is accepted for the diagnosis and they are reimbursed to use this ABPM. So this is a little bit different. They focus on the true patient with hypertension by using ABPM. And most of you have used this ABPM, and you know that some persons that say, especially at night, it hurts, I cannot sleep. And so the NICE guidelines tell the physician that if it cannot be tolerated, then you have to change to another mean of measuring blood pressure at home, and these are the devices of the patient, and there they have at least 7 measures to measure, and this is also different between the guidelines. So this is a first little difference between the two guidelines. Then, if you go into devices, I started speaking about ABPM, and you look what are the clinical indication of home blood pressure or ABPM, and you see that one of the causes is suspicion of white coat hypertension, and they focus a little bit on who are these patients. If you have hypertension at the office, which is a little lower over 140/90, then these patients have a high likelihood, depending on whether it's a woman or a man, or depending on the age, of having white coat hypertension. And their ambulatory blood pressure measurement, measured by ABPM or home blood pressure, is useful in excluding the diagnosis of hypertension. Finally, they talk also about a new concept, which is masked hypertension, which means normal blood pressure in the office, but high blood pressure in the ambulatory setting. So this concept is quite challenging for all physicians and all of us, because we cannot stay on our diagnosis or on our blood pressure level that we measure at office blood pressure, and this patient should be suspected, and they give some clues saying high normal blood pressure at the office, you should check, and normal office blood pressure with target organ damage. These patients, you should have a little hint, a little star that lights and says, okay, this patient, I want to go further, and I want to truly know if they are hypertensive or not. Then other indication for ambulatory blood pressure measurement are identification of a white coat hypertensive effect. That means treated patients which are still high in the office but can be correctly treated. If you take the resistant hypertensive patient, this is about 30% of the patients, so it's a real need to clearly assess the 24-hour blood pressure level or the home blood pressure level. When there's variability of blood pressure in the office, one time it's correct, one time it's higher than 140, then you say, okay, I want to have a better view of blood pressure, then you go for ambulatory blood pressure measurement. Finally, the patient who complains about fainting or hypotension, there also you can measure these changes in ambulatory blood pressure measurement and clearly diagnose those periods of hypotension. Finally, half of the world are women, and most of them have the chance to be pregnant, and ABPM should be a way to measure blood pressure because of the impact of having drug treatment in these women. You should be sure that they are truly hypertensive before starting a treatment if it's indicated. And finally, I just talked before about true or false resistant hypertension. You see that there's a high level of white coat hypertensive patient in this patient with resistant hypertension. So what's the difference between ambulatory blood pressure measurement or home blood pressure measurement? Of course, the ambulatory blood pressure measurement allows you to measure the blood pressure at night, which helps you also to give the patient a third view of his blood pressure. He says, okay, I'm controlled at home, but at the office I'm not controlled. If there's a clear discrepancy, go for ABPM. That can solve the problem. If you want to know what happens with blood pressure at night, and this is especially important for patients with diabetes, chronic kidney disease, for example, and you see this patient also with sleep apnea, then you should go for an evaluation of blood pressure at night. Finally, if there's a lot of variability, then again, it can be used in 24 hours. So I talked about the concept of masked hypertension. So when I talk to a physician, they say, okay, should we stop measure home blood pressure and just do ABPM for everybody, which would have a cost, of course. And then what is interesting is, I think the Austrian guidelines have pointed this out nicely, is to give you clues on how to identify the patient with masked hypertension. And this is clearly the case with normal blood pressure and target organ damage with left ventricular hypertrophy, for example. If you have a strong history of familial history of hypertension, then you should assess ambulatory blood pressure measurement. If you have obstructive sleep apnea, again, you should suspect masked hypertension. Chronic kidney disease, I talked already, and significant job stress, This can be discussed also. Excessive, for the cardiologists who are here, excessive hypertensive response to exercise, then you should suspect also masked hypertension. So this gives you clues, and I think the Australian did it quite nicely in their position paper. So what about risk? Of course, when you have a hypertensive patient, formerly you said, okay, he had high blood pressure, you want to reduce the blood pressure. We have seen that if you reduce the blood pressure with medication or lifestyle medication, you can reduce the risk, and this is why we should treat our patient. But the picture should be a little more large than just hypertension, and this is why the European Society of Cardiology and Hypertension have decided to have a broader view and to list risk factors or already diseases of this patient in order to evaluate the true risk. And this risk is evaluated in 10 years. So you can see on the table, sorry for that. You can see on this table that according to blood pressure, the level rises. This is not new for everybody. And according to the numbers of risk factors, then also the risk increases. If you have target organ damage, then you also have an increase in the risk. And this is one of the differences between the European guidelines and the American guidelines. There's a lot of stress on how to assess the risk of these patients. So, of course, you can easily put your patient in this table and say, okay, he has a high risk, meaning he has a high risk of cardiovascular events at 10 years. What this table doesn't show you is the effect of age. And of course, some of your patients may be young, no target organ damage, just hypertensive, and you say, okay, shall I start or not? And the effect of age in the score, for example, is very high. And this table doesn't help you with the young patients. And this should be stated for this patient. Having used this table, you can start to think of how am I going to treat this patient. So I will start with the right panel, the patient with very high blood pressure. And these you can start giving pharmacological treatment. You don't need to wait for changes, even if they have no other risk factors. If they are very high and they are proven that they are very high, you can start blood pressure reduction with antihypertensive drugs. And then, depending on the risk, you see that the lifestyle recommendations are recommended for everybody except the one who is not hypertensive, had no risk factors. Of course, you can do lifestyle changes, but otherwise, everybody can do this. And depending on the risk, you start with lifestyle, you can wait a little bit, and then you go to drug treatment, except for this very high grade where you start BP drugs or start BP drugs immediately. So once you have started the treatment, this is the next step in my presentation, is to achieve goals. In order to help your patient, you have to set goals in order to advance and to reduce the risk. So this has been a challenge of the last years where we thought the lower the better, and this evidence from that came from epidemiological studies, and there are not that much studies having evaluated to fix the target at a certain point. And this is why in the latest year, the new guidelines have came with higher levels of blood pressure. So now it's quite easier to have targets, because the target, once you treat your patient with hypertension, is to go lower than 140 over 90. And this includes patients with low to moderate risk, diabetics with a chronic kidney disease, patients with already cardiovascular events, stroke, TI, or coronary heart disease. So this is quite easy to fix the target. There are, however, some exceptions. In the diastolic values, the European Society says you can you must reduce diastolic blood pressure over 85, under 85, sorry. And the other concept, it's always with age in the elderly patient. And this, you will see thereafter, is a definition that can change. So the definition of elderly patient here is 80 years old. And in this patient, they say that there's solid evidence that you should reduce the blood pressure lower than 150. And they say between 150 and 40, or even consider for fit elderly that you can reduce over under 140 millimeters of mercury. Same target applies in older patients, which are in good physical and mental health. So what do other guidelines say? If you look at the GNC 8 that were released this year, of course, how you should manage hypertension, it is for adult patient, but if you look, when you have implemented lifestyle intervention and set your goal pressure, you see the general population and they divide in two, diabetes or chronic kidney disease, and the definition there is 60 years old. So one of the questions we should ask, what is elderly patient? Is it the level of fitness? Is it the true age? And this, you see, there's 20 years of difference between the European guidelines and the American guidelines. So this is interesting. And you see the level for people over 60, they set the level at 150 over 90 millimeters of mercury. So this is a true difference between the guidelines. I make a short quote from another Swiss cardiologist who is now in the United States. He looked at who is doing these guidelines. You had GNC 7, you had GNC 8, you have this panel. And what is interesting in GNC 6, you see that you had 11 persons participating to the guidelines. The mean level of publication for these doctors was 79 publications in the field of hypertension. Most of them were members of the ASH or AHA, and they were all, most of them were members of one or more editorial boards. If you look at the latest guidelines from the AHA, you see suddenly the persons are very different, and you see that the level of publication or the membership is different. So I thought it was nice to see also who gives you these guidelines and who should we trust, who should have the expertise, and this is always the question about guidelines. Finally, I switch also to the NICE guidelines. You see that also the NICE guidelines go for 80 years old for these patients. They set a limit below when you're under 80 years old, and if you're over 80 years old, they fix the limit to 150 over 90 millimeters of mercury. The NICE guidelines are maybe in advance because they say when you monitor blood pressure response, most of the guidelines say, okay, you follow on office blood pressure, but you see that there for people over or under 90 years old, they recommend also to follow with ABPM, and they set the recommendation to 135 or 85 when you're under 80 years old, or below 145 over 85 when you are over 80 years old. So finally, I will have a few words on the treatment. I continue with the NICE guidelines, and you say there's a clear dichotomy. This time it's 55 years old, and if you are younger than that, you can start with a blocker of the renin-angiotensin system. If you are over, you start with a calcium channel blocker or thiazide-type diuretic, and then you can add to this family, coming from both sides, either the blocker or the thiazide or the calcium, and you go over to a triple combination, and then if it's needed, you can add an alpha blocker or beta blocker. But what is interesting to also consider seeking specialist advice, because when you have a triple therapy and you are still not at the goals you have fixed, it is those patients which will have also a risk of have secondary hypertension, and then you should start to exclude this in this patient. What drug should be used? What is new in these guidelines? You see that first-line arteriside, angiotensin receptor blocker, ACE inhibitor, calcium antagonist. Beta blockers have lost favor, although they can be recommended. What is really new is not to associate an angiotensin receptor blocker with an ACE inhibitor. This is clearly due to the randomized controlled trial where you had the doppel blockade, which were not beneficial in terms of outcome in cardiovascular disease and had even more adverse event.
Okay, 12 minutes are over.
I come back?
No. 12 minutes are over.
Oh, okay.
You have to finish.
Okay, so just to say about how you should start therapy, you have in the European guidelines, you can choose between monotherapy or combination at first sight. Of course, you will choose combination therapy when you have highly marked BP elevation, because those patients will benefit to have a double combination, and then you can add a third drug or go for one agent, change to another agent, add another agent, and then you finally fall on the 3 combination. So in order to finish my presentation, I will also cite James P.A., who said these recommendations are not a substitute for clinical judgment, and decision about care must be carefully considered and incorporate the clinical characteristics and the circumstances of each patient. Thank you for your attention.
Thank you very much, Gregoire, for this nice overview. I think for having a lively discussion, we could change to French or German for the discussion. And I will start with the first question to Franco. Was bringen dir jetzt diese neuen Guidelines im klinischen Alltag?
Ja, ich glaube, du fragst mich als General Practitioner, das heißt als Hausarzt. Ich glaube, wenn ich eben Schlafprobleme habe mit diesen Guidelines, werde ich das lösen, sicher. Ich glaube, ich möchte gern sagen, das bringt mir aber eine Vereinfachung. Das ist eben so, Hans, weil, erster Punkt, ich weiß, dass ich kann nicht mehr auf meine eigenen Blutdruckmessungen bei meinen Patienten in der Praxis für eine Diagnose der Hypertonie stützen. Das ist der erste Botschaft. Der sogenannte Out-of-Office Blood Pressure Measurement kommt in erster Linie. Wir können eben die Leute besser beurteilen. Zweitens, wir können endlich noch einmal unterstreichen, dass wir sollen auch die sogenannte Risikostratifizierung besser machen. Das ist die zweite Botschaft von auch unser Freund Gregoire. Drittens, bei diesen Guidelines bin ich als Praktiker endlich eben einmal etwas mehr sicher, dass für alle Patienten gilt, weniger als 140 und weniger als 90. Das ist eben, was ich im Kopf halte.
Okay, vielen Dank. Vielleicht, bevor ich jetzt weiter die Diskussion führe, möchte ich noch kurz das Panel vorstellen. Georg Noll, Franco Muckli, Stefan Oswald und Francesco Siclari als herzchirurgischer Vertreter, Universitätsspitalvertreter, Praxis und einer Privatklinik. Bitte jetzt, Stefan.
Ich habe noch eine Frage. Kann ich auf Deutsch oder Englisch? You made the point of nighttime blood pressure 120/70, which is a pretty sharp limit. So how important is it that the patient sleeps while you measure the blood pressure? And how do you ensure that he's sleeping when you have only nighttime hypertension?
The question about the quality of measurement when you measure nighttime blood pressure has been raised a lot. And finally, what I could answer, maybe indirectly, is when you look at the information that is provided by nighttime blood pressure, independently of the quality of the sleep, it is that over daytime blood pressure, over office blood pressure, it gives you the strongest risk assessment of what the blood pressure is.
But you're speaking about 120/70.
No,
you diagnose,
I will answer to you. It is true that when I speak about the prognostic factors of nighttime blood pressure, of course, this is a curve which all curves of blood pressure, and to set a limit is like setting a limit of hypertension at 140/90. This is based on a cutoff, but of course the risk with all blood pressure is that from one level of blood pressure to the highest level blood pressure, the risk goes up. So it's a cutoff that is chosen.
Maybe we misunderstand each other. I'm asking if you have an isolated nighttime hypertension, 130/85,
yes.
Nighttime hypertension. Daytime is okay. Do you treat the patient?
No, because the evidence of reducing nighttime blood pressure, we have none. The evidence we have of reducing blood pressure and reducing the risk all comes from office blood pressure. And we need the data with ambulatory blood pressure measurement for the targets, on which targets we should use. And now I understand the question, and it's a very important question. So for the diagnosis, there is no problem. For setting goals, we need more data, and we need maybe clinical trials. This will be difficult to say, okay, we will fix ambulatory blood pressure targets, different ambulatory blood pressure targets, or nighttime blood pressure targets to see how low we should go.
Question de l'audience, oui. On peut parler allemand, français, English, what you want.
Thank you very much. One question, is it possible to reduce endpoint mortality with the only use of ARBs drugs to treat hypertension?
This is a question of which drug you should choose to reduce your risk. I think the first point is to reduce blood pressure, and the reduction in cardiovascular event. There have been a lot of meta-analysis analyzing beta blockers, blockers of the renin-angiotensin system, diuretics, calcium channel blockers, and all of them have shown a reduction in cardiovascular events when you reduce blood pressure as monotherapy. And of course, you have to add that most of the patients do not have only monotherapy, and the difficulty is always to see, okay, to this reduction of risk, which drugs had more impact when you associate two medication. So for your question about ARBs, or blockers of the renin-angiotensin system, they have shown that if you reduce blood pressure, you reduce the risk of cardiovascular events, as you reduce with other monotherapy.
Georg?
Ich habe nur ganz wenige Bemerkungen. Das erste ist, ich glaube, 24-Stunden-Blutdruck wird mehr Wert darauf gelegt, aber als Diagnostikum. Wir brauchen den 24-Stunden-Blutdruck grundsätzlich nicht, um eine Therapie zu kontrollieren, weil wir wissen gar nicht, wie die Werte sein sollten im 24-Stunden-Blutdruck unter Therapie. Das Zweite ist, was mich mehr verwirrt hat, als dass es mir Klarheit gebracht hat, ist die Einführung und das Gewicht, was man auf Masked Hypertension gelegt hat. Masked Hypertension ist eine Neuerfindung der letzten Jahre, und das sind die Leute, die eben erhöhte Blutdruckwerte haben, nicht beim Arzt. Jetzt, man sagt sehr schön, man soll die bei denen suchen, die Endorganschäden haben. Der kommt zu mir, hat einen normalen Blutdruck, suche ich dann Endorganschäden, oder? Das ist ein bisschen das Problem. Also das heißt, wir müssen zuerst allen Leuten Endorganschäden suchen, bevor wir überhaupt einen Blutdruck messen. Also ich glaube, das ist etwas, da wissen wir noch relativ wenig darüber. Wir wissen auch nichts über die Zielwerte einer Masked Hypertension, und deshalb, ich glaube, es ist ein interessanter Aspekt, aber wir wissen da noch etwas zu wenig, wie wir da therapieren sollten. Und auch, ich glaube, die Blutdrucksenkung ist das Wichtigste. Ich denke, die NICE-Guidelines sind die einfachsten, Calcium-Antagonisten oder Hämmer des Renin-Angiotensin-Systems und dann Diuretika und andere Medikamente. Die MR-Antagonisten sind eben etwa vierte Stufe, und das sind erfolgreiche Medikamente bei sogenannter therapierefraktärer Hypertonie, also Leute, die 3 Medikamente inklusive ein Diuretikum haben und immer noch erhöhte Blutdruckwerte. Das sind sicher etwa 10 bis 15% Leute, die einen Hyperaldosteronismus aufweisen. Renale Denervation, da sind die Bücher nicht geschlossen. Ich glaube, es sind Konflikte, also unterschiedliche Resultate. Die letzte präsentierte randomisierte Studie hat keinen Effekt gezeigt im Vergleich zu einer adäquat oder intensiv behandelten medikamentösen Gruppe, wobei man sagen muss, auch dort ist der Blutdruck erstaunlich runtergekommen. Ich habe das noch in keiner anderen medikamentös behandelten Studie gesehen, dass wenn eine medikamentöse Therapie mehr oder weniger gleich gehalten wird, dass der Blutdruck weitere 10 mm Quecksilber systolisch reduziert wird. Aber ich glaube, es hängt davon ab, auch vielleicht von der Technik. Ich glaube, heutzutage, es ist immer noch vorbehalten, einem Hypertonie-Spezialisten einen Patienten allenfalls einer Nierennervendenervation zuzuführen.
Möchte noch jemand ein letztes Wort haben zu diesem Thema?
I will shortly add something on mask hypertension, just to challenge Professor Noll. I agree with him that we don't know if we should treat this patient, but the risk associated with mask hypertension is equal to the risk of a truly hypertensive patient. And when you evaluate a patient that comes to your office that has normal blood pressure, of course you say he's normal, but if he's close to hypertension, you would automatically have a hypertension workup where you would do at least an EKG or creatinine or albuminuria, and then you have not all the target organ damage, but you have some. And if you have a high discrepancy, then you should suspect this patient. But it is a challenge, and I agree, we don't have sufficient data also to recommend how we should treat this patient.
Gut, vielen Dank. Der Chirurge möchte hier nicht das letzte Wort haben, sondern vielleicht dann beim nächsten Thema. Vielen Dank.